All, sorry for the slight hiccup, some technical issue. At the outset, I thank Dr. Lokesh and Dr. Uday for giving me this opportunity to be a part of this wonderful event which was organized here. Today, I'm going to discuss about a basic, I'm going to take you through the basics of diagnosis of a lymphoma, what we should not miss in our day-to-day practice. So this was a question for me when I joined my training for oncology. What is a lymphoma and what is a leukemia? So lymphoma is nothing but a clonal disease of blood cells and lymph nodes. They usually lymphocytes originate in the bone marrow, travel through the body, and finally to the lymph nodes. Lymphoma and leukemia are almost overlapping. Leukemia is defined by presence of malignant lymphocytes in the circulation, whereas lymphoma, it is just confined to the lymphatics. So there is an overlapping scenario where a lymphoblastic lymphoma, it's disease of a mature lymphocytes overspilled into the circulation. These, even though it is a lymphoma, it is managed in the ways of a leukemia, acute leukemia. Whereas CLL, chronic lymphocytic leukemia, is a disease of mature lymphocytes but managed as per lymphoma or indolent lymphoma. So we have few diseases overlap in clinical picture, but the treatment also is different for few certain leukemias and certain lymphomas. So these are the WHO or ICC classification of a lymphoid malignancies. We have a spectrum called precursor lymphoid neoplasms. They are either precursor B-cell lymphoid lymphomas or leukemias, or precursor lymphoblastic T lymphomas or leukemias. Others are mature B-cell lymphomas and mature T-cell lymphomas, and a separate entity called Hodgkin's lymphoma. So mature B-cell and mature T or NK cell lymphomas are non-Hodgkin's lymphoma. So broadly classified into either leukemias or Hodgkin's or non-Hodgkin's lymphomas. Coming to the pulmonary manifestations, we have two different categories, the primary pulmonary lymphomas or secondary pulmonary lymphomas. Multiple ways of pulmonary manifestations can be seen across the spectrum. Most of the time they overlap with underlying pneumonias, underlying tuberculosis, underlying autoimmune disorders. It is a diagnostic challenge. They can present as large masses, consolidations, effusions, ground glassings, lymphangitis spread, or effusions also. The most common symptom is a mediastinal or hilar lymphadenopathy. Coming to primary pulmonary lymphoma, this is defined as presence of lymphoma only in the thoracic cavity. When there is a complete workup is done and when we can't find any other system involved outside of the thoracic cavity, it is called primary pulmonary lymphoma. It is very rare, less than 0.5% of all the lung neoplasms or less than 1% of all lymphomas together. Whereas secondary lymphomas, these are pulmonary manifestations of systemic lymphomas. So pulmonary lymphomas, they are almost 85% of the Hodgkin's lymphomas patients will have either mediastinal lymphadenopathy or a pulmonary manifestation. At least 50% of non-Hodgkin's lymphoma patients will have a pulmonary manifestation. Out of that, 24% is a parenchymal disease. I would like to take you through few images where these lymphomas presented in the thoracic cavity. So this is a CT of a 50-year-old patient presenting as a pulmonary mass, and this mass, when biopsied, turned out to be a T-cell rich non-Hodgkin's lymphoma. So initial diagnosis was a consolidation which was treated initially for a few days with antibiotics. It was not responding to antibiotics. Patients were becoming symptomatic. Then there was a biopsy done and there was no disease elsewhere except for this mass in the lung. So even the corresponding PET scan can show a enhancing mass with a SUV uptake. Is another CT scan of a 27-year-old male patient presenting as a lung mass with a large homogeneous soft tissue density. And it was biopsied initially from the periphery, which was necrotic. He was treated with few antibiotics, few days of antibiotics. There was no response. And then a PET scan done showed an enhancing mass in the center. So then an image-guided biopsy so that it was done so that the tissue is taken up from this enhancing area. So this turned out to be a diffuse large B-cell lymphoma of a pulmonary type. So another patient of 27-year-old presenting with soft tissue mass with mediastinal lymph nodes. The diagnosis was a primary Hodgkin's lymphoma. All these patients had no extrathoracic manifestations. So the primarily differences between non-Hodgkin's and Hodgkin's usually present as a single mass or multiple nodules in the upper lobe distribution, and mass-like consolidations in almost 80% of the cases, and mediastinal lymph node enlargement is more common in Hodgkin's. Whereas in non-Hodgkin's lymphoma, it is more of peribronchovascular interstitial thickening, and mediastinal nodes are as less than 20%. This is another patient with secondary lymphoma, which manifested as diffuse lung nodules and GGOs. The arrowheads are GGOs. So this patient is diagnosed to have secondary DLBCL, which has systemic manifestations. Few patients who present just as consolidations. This is a 67-year-old patient on the left, presenting with a patchy consolidation and bilateral nodules. And the right side is a 29-year-old male presenting with a non-resolving consolidation. Eventually, the biopsy proved to be DLBCL. So another case scenario where it is just a perilymphatic spread. This is a systemic manifestation of a DLBCL. So it is a pulmonary manifestation of a DLBCL. So coming to clinical presentations, so we have two types, both aggressive and indolent. Most of the time, primary pulmonary lymphomas are indolent. They give time for diagnosis, and the clinical spectrum ranges from few months to years. Whereas systemic or secondary pulmonary lymphomas or aggressive B-cell lymphomas, they progress very rapidly. So coming to aggressive lymphomas, the presentation is initially from days to weeks. So usually it is associated with lymph nodal enlargement and splenic enlargement. Neurological deficits like when CNS involvement is there, we can find seizures, tremors, CVA, cerebellar symptoms, etc. Whereas pulmonary symptoms, as usual, cough, dyspnea, chest pain, hemoptysis. Most of the time, if there is a mediastinal mass, we do see superior vena cava syndrome, which is an oncological emergency, or any pulmonary venous thrombosis or any deep vein thrombosis can occur. If there is a recurrent laryngeal nerve involvement, we see hoarseness of voice. If at all any patient who presents with lymphadenopathy has cytopenias, it is usually bone marrow involvement. So systemic generalized lymphadenopathy with cytopenias, most of the time the patient will have an underlying bone marrow infiltration by the lymphoma. So rather than getting a biopsy done, if we just get a bone marrow aspirate, the diagnosis will be faster and we can start treatment as early as possible. Coming to B symptoms, which are not specific to lymphomas, they are equally good in all granulomatous diseases also. But we do see fever, weight loss, more than 10% of weight loss in the last 6 months is a concern for us. Along with that, pruritus and drenching night sweats. That very typical patients do complain in TB, but patients with lymphoma do complain that their dress at the night wear get drenched with sweat. And other paranoid neoplastic syndromes like nephrotic syndrome and anemias, hemolytic anemias, and thrombocytopenias also are seen. This is a primary mediastinal large B-cell lymphoma where this is a pure pulmonary manifestation where patients won't have any other systemic disease. Most of the time it's an young female in the late 30s. Presents with superior vena cava syndrome, respiratory distress. So this is diagnosed and this diagram it showed we can even see superior vena cava is occluded and they had kept open by using a portacath, and this lymphoma is encasing the aortic arch and displaces the trachea posteriorly. Coming to indolent lymphomas, they are slow growing, they have waxing and waning courses. As I told you, there will be like few months to years of presentations. And they are not curable because indolent lymphomas are they don't even need treatment in many of the times except when the patient is symptomatic. So they do present very indolent course. Major subtypes which we see in pulmonary are marginal zone lymphomas and follicular lymphomas. Coming to the approach, the duration of symptoms should shed us a light whether we are dealing with an aggressive lymphoma or an indolent lymphoma. And along with that, HIV infections, most of the patients with HIV can present with Burkitt's lymphomas. HCV can be presented in follicular lymphomas, whereas H. pylori can be seen in mild lymphomas. And autoimmune diseases and chemicals, and any breast cancer patient who presents with a mediastinal mass and who had received prior radiation therapy to their breast cancer, we have to suspect a lymphoma, mediastinal lymphoma. Coming to examination, lymphadenopathy examination is very crucial in determining the staging and making a diagnosis. Most of the time, this lymphadenopathy is often overlooked. We do see people getting treated for tuberculosis or any other infectious causes with multiple doses of antibiotics, steroids, and without even getting a biopsy from a lymph node. So patients come to us late in presentation, and we don't even, by the time they come to us, they will be on a long course of steroids, and the lymph nodes will be regressed, and for getting a diagnosis will be very issue. So coming to making a diagnosis, core biopsy is most important, and we need immunophenotype, we need molecular studies and a bone marrow for staging purposes. So excisional core biopsy is the gold standard, not even the true cut biopsies or an FNAs. Never attempt an FNA, and we have a we have a set of guidelines on whom to biopsy, which I will be talking later. So these are the worrisome features in children who present with lymphadenopathy and who need a biopsy at front. So early biopsy in few patients, in children, especially in 10 to 15 years of age, who present with an ongoing fever for more than a week and other B symptoms. Supraclavicular node, any children presenting with supraclavicular node should be biopsied. So there is no other excuse to that. All the patients, children presenting with supraclavicular node, and if the load is at least 1 centimeter, it should be biopsied. And the biopsy should be an excisional biopsy rather than a true cut biopsy or a core biopsy. Why excisional biopsy? I will be talking later. And along with that, any other like elevated LDH, any other absence of clinical features of infection, abnormal chest, mediastinal widening, any cytopenias, all these patients we should definitely do a biopsy, lymph node biopsy. Coming to the draining areas, the supraclavicular, almost most of the time, if there is a right supraclavicular, the draining area is from the mediastinum or lung, and if there is a left supraclavicular, it's the draining from the abdomen. So if there is a abdominal malignancy, and especially in adults with at least 2 centimeters of supraclavicular node, always suspect an abdominal malignancy. Whereas if it is on the right side, we can suspect a mediastinal or a lung pathology. Supraclavicular lymphadenopathy is associated with the highest risk of malignancy when compared to other lymph nodes. Almost 50% of the patients with supraclavicular lymphadenopathy will have a malignancy, especially in patients above 40 years. Less than 1 centimeter lymph node in any group is almost non-malignant. So role of biopsy, when to biopsy a patient. So persistent nodes greater than 4 weeks in adults without resolution, greater than 2 weeks in children, you need to go for a biopsy. If there are any worrisome features, in children especially, they need to be biopsied upfront rather than before giving a trial of antibiotics or symptomatic management. If there are no worrisome features, we can wait for up to 2 weeks in children and up to 4 weeks in adults to get a biopsy done. And nodes greater than 2 centimeters in adult are very hard and fixed nodes in the supraclavicular area, and they should be biopsied. Coming to the importance of an excision biopsy, in order to confirm a diagnosis of a lymphoma, we need to know the architecture of the lymph node. Simple FNAC won't give us any insights. Looking at the lymph node specimen here and the histopathology, the topmost the topmost picture is showing sheets of lymphocytes arranged in clear follicles. So this is nodular, and the diagnosis will be a follicular lymphoma. Whereas in the bottom picture, it's a diffuse effacement of the lymph node. It is diffuse large B-cell lymphoma. So in order to know this architecture of the lymph node, we need an excision biopsy. True cut biopsy and FNACs won't give us the insights into the type of lymphoma. And we need tissue for further tests like immunohistochemistry, molecular evaluation, everything we need a tissue. So core needle biopsy or EBUS biopsy or an FNAC won't give us a sufficient tissue. All these are to be looked at by our pathologist when we are giving a diagnosis of a lymphoma. The size of the cell and the pattern of the lymph nodes and the nuclear shapes. Coming to staging, now PET scan has replaced the conventional CT scan in all lymphomas. It gives us a clear-cut picture where there is an involvement of lymphoma. Along with that, it gives us insights into the treatment response. So all our lymphoma managements are now PET-adapted treatment responses. So if there is a good response to treatment, we can de-escalate the therapy. If there is a bad response to therapy, we can escalate the therapy. So almost invariably, all the lymphomas will be restaged, or second PET will be, we call it PET2. It will be done at least 2 to 4 cycles after starting chemotherapy. And these scores which were given as dual scores will guide us in diagnosis. Dual 4 and 5 is always positive for lymphoma. Dual 1 to 3 is negative for lymphomatous involvement. Why early biopsy is important in lymphomas? As the time progresses, the evolution of stages increase. From stage 1, patients go to stage 4. As the stages increase, we assess a patient based on this ECOG performance status. As the stage progresses, the performance status drops. So the stage progresses, the response to therapy drops, the recurrence rates increases, and tolerance to chemotherapy falls. So all patients who are identified in the first 2 stages and having a performance status of 0 or 1 are easily manageable when compared to patients who presented with stage of 3 or 4 with performance status of higher performance status. I would like to show you an interesting case where this 14-year-old kid was evaluated elsewhere, progressive breathlessness. This was during the COVID time. He was maintaining stats, though he was breathless on exertion. He was maintaining stats. He had cough and he had no cytopenias. He was evaluated elsewhere. They found him to have a small mediastinal mass. So he was sedated. He was planned for a procedure of biopsy, transthoracic biopsy. He was sedated. The moment he was sedated, they could not maintain his pressures. So because of that compression by the mass. So he was rushed into our ER in middle of the night one day. It was very difficult for our ICU team to manage him. By the morning, when we got a call about this, there was a huge pleural effusion. So even pleural effusion, we had sent a pleural fluid analysis for a flow cytometry. We got the diagnosis of a T lymphoblastic lymphoma in 5 hours. We had started him on steroids. So that steroid, because TLBL is managed in the lines of leukemia. By starting steroids, he was stabilized he was hypercapnic, he was not maintaining, the machines were struggling to maintain him. So at the end of 5th day, he improved, and this kid was awake. We couldn't wean him off early because of his weak pulmonary architecture. So, but we could wean him off. Sorry, the video is not playing. So this kid was active. He was on ventilator for almost 2 weeks, but he was active, awake. He was playing. He was doing the Rubik's Cube within a minute time, and he had good time in our ICU. I never saw such a happy patient in the ICU. Everyone were happy. His mass had come down. His pleural effusions had come down very fast. Eventually, he could come out. So any mediastinal mass just before sedating the patient, make sure that we have all the necessary equipment to maintain him, or else we might lose the patient. So the video is playing now. This guy is playing, and our intensivist sir is making some jokes with him. So in the management of lymphoma, everyone will have tools. Multiple tools are available. We should know the right tool for the right job. We can do an EBUS biopsy, we can do an excisional biopsy, we can do a bone marrow biopsy, we can even send a pleural biopsy, pleural fluid analysis, anything. But each patient has a different need, and each patient will be managed differently. So it is an interdisciplinary approach where all the team, pulmo team, critical care team, general physician team, and onco team are to come together and work, and with extensive support from the lab. The same thing, multiple diagnoses and many treatment options. In conclusion, I would like to stress that always a lymph node evaluation is very critical in diagnosing a lymphoma, whether it might be a pulmonary lymphoma or a systemic lymphoma, and PET-CT and biopsy are essential tools for us. Early detection and accurate staging gives a good chance of patients to survive the lymphoma. Thank you.
That is an exhaustive presentation, sir. There are any questions? Or else we can go for the panel discussion. We'll go ahead with the panel discussion.